Hello, hello, everybody. Okay. Yeah, I have an special guest. I have my resident Dr. Rodney. Thank you for coming. Okay, so how's everybody? Everybody good? Have a good lunch? I hope. Okay, remember, this is like a Netflix. We want to recap. Last time we talked about some and the journal of movement disorders, but today we're going to go back a little bit our review of the New England Journal of Medicine. Again, interesting enough. Mr. Parkinson's make the diagnosis of make the description of Parkinson's in 1817. 1 year, 100 years and 1 year additional in 2000, in 1918, we had the first pandemic, the Spanish flu. 100 years and 1 year more, 2019, we had the second pandemic. I don't know, it's a constant, 1 year and one, so 101, like 101 Dalmats or something like that, So let's go with the presentation of today. I haven't received any pictures from you guys. Remember, you have any nice picture, share with us. I love the sunsets. This is a street of two ways. Remember, I love the sunset. So you have any nice pictures of sunset? That's one of my hobbies. You can participate in hobbies. You have any nice picture of sunsets or sunrise, share it with us. Send it to us and we place in the next presentation. Okay. So we talked a lot last time, just to remember, this is the recap. We talked last time about another reasons to have Parkinson's. We have a description just for Dr. Rodney. We have a secondary etiology for Parkinson's. There was a description and case in the movement disorder journal for amoebiasis, the Entamoeba producing Parkinson's. So we won that case last visit. And then actually we describe that, and actually you can see in the microscope that amoeba, and that patient initially had Parkinson. This is not an amoeba. This is the orange moon that we have recently here. And this was the description of the case. In the MRI, we found there was a little dilatation in the lateral ventricles and the third ventricle. In that case, again, the secondary etiology for Parkinson's, that's not the typical. But again, sometimes we can make diagnosis of Parkinson's. Actually, again, from everybody, Dr. Rodney, we get usually in MRI, we have Tesla 3. We're not talking about cars. We're talking about the MRIs, right? So Tesla 10, we actually can look in the midbrain in the substantia nigra, and with that, we can make diagnosis of Parkinson's when it decrease the density of the substantia nigra. So we talk about secondary Parkinson's. So I had to point out again the COVID-19. We had some people having Parkinson's after COVID, especially you get lack of sense of smell or taste. It is very bad. Hopefully I will not get it in the future, but I have COVID instead of having all my vaccinations. But it's a mild, usually not, so we'll see. So there's a lot of things in the clinic, we see a lot of long COVID. Just today, a couple of people mentioned about the COVID again. So we got to this story again. We talk about 1817, the description, 1918, Mr. von Economo described a Parkinson's associated with infection with the encephalitis lethargica, meaning the flu or the Spanish flu producing encephalitis, and the encephalitis producing Parkinson's. In that case, it was a variant of Parkinson's. I told you just to watch that movie, The Awakenings, with Robert Williams, Robert De Niro. Actually, he did a good job doing the dyskinesias. But you see these people that don't move, and he sent a tennis ball and he catch it here. And then they describe how the dopamine or level dopamine by then was starting in these people, and they awake. They were like sleepy, the dopamine, and they awake and they were able to move. But some people were taking too much and got the dyskinesia. And between others, we talk about Epstein-Barr virus, varicella zoster, but for the most part, it still said the Parkinson's is idiopathic. Again, we always say idiopathic as idiots, we don't know, but 85% we don't know. But we always fill our mouth to say, we know, it's idiopathic. Oh, this doctor knows a lot. No, we don't know. So basically, it's 85% or no, but we notice now more and more investigating. We have been talking about air pollution. We're talking about people in military with exposure to Agent Orange. In Florida, the paraquat, the pesticides, we have very nice crops of orange, but these people, and then investigate, and some people say, oh, the products, how we fed our cows, how we get the milk, it is this how they feed with this the grass is get pesticides, we get the pesticides in our body through that kind of thing. So we have to be sure when you get you die, be sure it's not going to contaminate it from that. Okay, so this again, this is a recap. I'm not going to go this thing because we did already. This is a recap from the previous. Okay, so we reviewed the case and actually we found there is some biomarkers. So nowadays we have an infection, we have to look if there is alpha-synuclein. How the inflammation, how these toxins make the alpha-synuclein is a misfold protein producing Parkinson's. So that's that we're going now in research how we can cure or treat Parkinson's. So this is well in the Mediterranean that was in close to Barcelona. Hopefully, knock on good, I can go to Italy. We have been not having any vacation because the COVID. We celebrated 35th anniversary with my wife, so we're planning. That's when moving in the house. Hopefully, can get to Tuscany, Venice. So I Stanley live your life. Remember, I have a very nice cartoon. Somebody in Venice, and they got in a gondola. We planning to go vacation, and finally we get sick or get old. We don't go, and then in the picture, the people, the gondola doing the thing, and the two people, the couple, just sleeping. So life is now, remember, enjoy it every day. Usually we look for the past. The past is there, it's an experience. It's just something to remember. The future doesn't exist, it's now. You have to do it now, right? You always say, now in the future, when I have this. And then when I wasn't a teenager, I want to be older. Now when I'm older, I want to be a teenager. So, so you have pictures shared with us. This is life. Hopefully I can show you something in Venice. Hopefully I can get there. Okay, so we're talking about deep brain stimulation and talking about in the GPI in people with dystonia. We showed those videos last time, but let's go to the main thing we're going to discuss. Again, in October last year, in the New England Journal of Medicine, were described, they went update about Parkinson's disease. By the way, April 11 was the International Day of Parkinson's. You know that, right? Yeah, I tried to place a thing right here, but it's the awareness. We have to have a little celebration, the Parkinson's. And for now, in April 11, we have to try to do something. Okay, so you see, this is a very significant amount of people having Parkinson's disease. So we have been getting, we're talking about 1 million. I say we have more than that. And the last update of Parkinson's disease and the New England Journal of Medicine was in 1998. So it had been a while, and yes, last year we have this update. So let's talk about the incidence, and let's go back a little bit of this. Incidence and prevalence. We talking about disease. We try to talk about the new cases. I'm glad I have him in silence. Nobody's calling me. It's my brother. I cannot answer now. So the incident is the amount of new cases in 100,000 people per year. And the prevalence is going to be the new and the old cases in that population by 100,000 people in a year. So we see here, initially we called how the prevalence or how is the ratio between men and female. Initially we're talking about 3 to 1, but now it's 2 to 1. So we see more cases in females. Looking as well for the age. So they go from 47 to 77 cases in 100,000 in people of 45 years old. The older we get, the more prevalence or incidence. So if somebody getting more than 65 years, and the prevalence and the incidence increase very significantly. So the older we get, the more risk to have a Parkinson's disease. Now we look from the race, so looking at the ethnicity. So most of the studies on and white, but I see this well It's prevalent across the board in all the ethnicities, but definitely it's more prevalent in white than. And of course, we are living here in more in a population in whites, but we see some, like, some Hispanic. I have in my population is some people, but the main population that I see is whites, and as well that's exactly what the journal says, and as well we have some African Americans, so it's very prevalent, and we see that the costs from the health is 52 billion in 2017. I want to increase up to 79 billions in 2037. So unfortunately, it's a condition will continue. So you see, because this is have been increasing incidence and prevalence, we're doing a lot of research to try to find out the cure, and the same we're doing with Alzheimer's. You know, we have, I mean, while we really propaganda our memory clinic, we have 2 medications now for Alzheimer's to try to modify the progression, taking away the alpha amyloid. So we're trying to do the same in Parkinson's. There are several studies, and actually we were presenting in the New England Journal of Medicine. Definitely they're doing monoclonal antibodies against the alpha-synuclein. They have been trying medication for cancer like Tasigna that is used for lymphoma. That was my mentor, Dr. Pagana, about 6 or 8 years ago. I still don't have that. And I think soon enough, will be one researcher coming to talk in the Parkinson's place about the cure. And I think they had, I don't know if he came already, but it's in this month. So we don't have the cure, but we know right now, we always talk about exercise, right? Okay. We have to talk about the recycling, MLB inhibitors. Unfortunately, nothing else I can say is neuroprotective or slow down the progression more than exercise. But recycling or Asilec is a medication I give somebody starting with Parkinson's, because that's the cherry in the cocktail. That decrease for sure or modify the progression in 4 points. You remember that Unified Parkinson's Disease Rating Scale is the way I see how you progress. That score is going to show me the higher the score, the worse, like people playing golf, right? You know what the handicap, the higher you score, the worse. The same with Parkinson's, the higher the score, the worse. So definitely exercise, neuroprotective, and recycling as well can improve that. So there's a lot of evidence. Back in my fellowship, back in 2008, so I've been like a long time ago, we used that medication, and some medication was discovered in Tel Aviv in Teva, which is one of the most of the biggest companies for generics. And since then, I'm very convinced that medication is a miracle for the people in the audience that are using. You know, really, it really works. I had somebody start with that, and she didn't come today. But again, this medication has been very good. Many people forget about what they prescribe the recycling or Asilec. They say, no, there's not doing anything for me. Look, my tremor is the same. But we found that actually empower the carbidopa-leopa, decrease the progression of disease. Again, unfortunately, I had no evidence because the studies were not good to show that, but definitely improved 4 points in 6 weeks. So people say, no, I'm doing anything. I said, come on, let me see. And I repeat after 6 weeks, my UPRS, I said, yes, it's working. And we noticed there is some study for cognition. Can you prove one score in a mini mental status exam that usually study? So that's very good medication. Okay. So remember, we're talking about Parkinson's, or we talk about sometimes as well Parkinsonism. Again, not all that you have is Parkinson's, and some people can with multisystem atrophy, pure autonomic dysfunction. I discussed this morning with Dr. Ronnie about somebody coming with autonomic dysfunction, and actually ordered a DAT scan, and they were not very convinced that they have Parkinson's. And then actually the radiologist read the DAT scan that was normal. And said, Dr. Ronnie, let's do this, look this the DAT scan. I showed them the shape of the coma, and they said, no, I don't think it's normal. And let's see, let's take a look at this. So the right side of the brain control the left side. I noticed the decreased dopamine was more the right side, and the patient present with tremors more in the left side. So I said, it goes very well with it is. It has a little flavor of Parkinson's, but the tremor is so mild. The main issue is the orthostatic hypotension. So I probably has some atypical Parkinson's and have just a little flavor of lack of dopamine. And then medication for him like dopamine is not very now, because the people suffering from orthostatic hypotension, we know that actually dopamine can make the blood pressure low. And actually, one of my patients said, no, my colleague said, no, that's you're wrong. That the dopamine doesn't decrease the blood pressure. So I had to disagree. And I see every day, every single patient and people suffering from this condition know that actually dopamine is not helping them. Actually, it can make the orthostatic hypotension much worse, especially immediate release. Okay. So looking about other symptoms of Parkinson's is not only tremors. Parkinson's or Parkinsonism can produce what we call non-motor symptoms, like the REM sleep behavior. Remember, your partner started screaming. There's no excuse to hit your partner, getting a punch in the face. But I see a lot of people falling from the bed, getting in the ER for head trauma. So this could be very serious. REM sleep behavior as well is not only presented, is so not prevalent in Parkinson's sometimes, but in some Parkinsonism, especially Lewy body dementia, is big. So remember, it's not black and white. And again, we're looking for no motor symptoms. Sometimes we talk about the lack of sense of a smell that have present for years and years before you had the tremors. Constipation that come before that. Issue with the sleep, issue with anxiety, issue with cognition. So all of this, again, is not only tremors. So sometimes say, no, I don't have tremors. So how come you tell me I have Parkinson's? Okay, so there's two types, again, of Parkinson's, one with tremors and one is no tremors. It's difficult just moving or have a difficult moving or having apraxia. So one of the things that I recommend always to look is go to the source where you get the information. So I said one of the main journals to look is the New England Journal of Medicine, or the journal that we have from the International Movement Disorder Society, which I belong, and I love it. And we have been seeing videos, and so far I recommend you to go to that. The National Parkinson Foundation, we have a lot of research. And many people come to my office and said, I have this, how you hear about this? I say, probably not. There is too many. There is a lot of research, and you go to a puntual one. I in previous talk showed to you how many studies are ongoing. But in any case, some people say, you haven't heard, you probably have to get more up to date, doctor. I said, okay, thank you. But you get me a little more information. I appreciate it. So sometimes because we don't have, it's not black and white like this, just autonomic dysfunction, just having difficulty swallowing, or some people come only with fascination, walking too fast, with the blood pressure, or people come with the memory and hallucinations, a little bit of feature of Parkinson's. Sometimes we need to get the DAT scan. The DAT scan actually is getting more popular, it's a biomarker. So we can look the DAT scan, and nowadays we get as well the skin biopsy. And so with my partner, Dr. Roth, and in our office, we try to get the biopsy for somebody needed for insurance. Again, I trust my training, but I trust as well there is a biomarker where there's a doubt. But some people need for insurance get the biopsy, so we can go there. So the SPECT is something that we're doing right now in biomarkers. So let's go for the key points about Parkinson's. So remember, Parkinson's cannot be defined only for tremors. So we know it's a progressive degenerative disease. Is produced by a misfold protein is called alpha-synuclein. What that alpha-synuclein is packed in a small, like in a small globes or packets, we call the Lewy bodies. So Lewy bodies is actually when you see somebody in the past, when somebody was dying, we did a sample of what happened in substantia nigra in the midbrain, and we found the Lewy bodies. So Lewy bodies is the alpha-synuclein in clusters, and this is the way we made the diagnosis before all other biomarkers of Parkinson's disease. But you notice, you hear more Lewy bodies when somebody have dementia. So it's called Lewy body dementia. So people have Lewy bodies, but it's only that. No, Lewy bodies is something is present in people with Parkinson's. Can be only in the gut in the beginning, producing constipation, can ascend from the vagal nerve to the nucleus of the vagus initially. Some people have autonomic dysfunction because of that. And finally, we progress a little higher and go to the substantia nigra when you start having the tremors. But in this condition of this alpha-synuclein goes at once very fast to the cortex, then we people have Lewy body dementia. So that happens, I'll hit the cortex at once like that. People that having problem with cognition, they having their sleep, and later on time, people with that dementia, with hallucinations, REM sleep behavior, at some point they start getting some tremors, get some flavor of Parkinson's, slowness, tremors, shuffling gait. We talk about the mood and the sleep. So we're talking some people getting anxiety, depression, cognition. So we're looking for some gene variants. So we talk about 85%, we don't know the reason, but there is some Parkinson's actually that happens in families. We know people, brothers, have several families that have the gene or have a mutation. And then in Jewish, and the Ashkenazi, we have an LKK2 mutation. And we're looking more, and the more we investigate, we're getting more mutation, I think. So the 85, we probably want to look at more 70 idiopathic. And the more we study, we're getting more reasons to have Parkinson's. So as mentioned before, no therapy, no medication have been shown to be neuroprotective, meaning no therapy have been shown to slow the progression. That's why we obligate to say the only thing is neuroprotective in Parkinson's is exercise. Remember, don't get too excited to do too much exercise and injure your knee or your ankle. I don't want to hear that. Because if you have that, then you don't do exercise and you progress faster with Parkinson's. But before, and then again, this is the New Journal of Medicine, we're looking for medication have been proved or tested on research for neuroprotection. And the resalidine was one of those. Amantadine was another one. Combination with dopamine agonists. But so far, there is no one that we can say is neuroprotective because we have to look only with evidence. So talking about the no-motor symptoms, because again, Parkinson's is not only tremors. The no-motor symptoms are very important because they can produce what we call morbidity. That means difficulty. Morbidity means disease, or mortality. Mortality means people dying because complication with Parkinson's. Usually Parkinson's will not kill you. That kill you is complications. Cancer, falls, aspiration pneumonia. So we need a biomarker for looking the reason to have Parkinson's or Parkinsonism. And we found it now, and we're looking about the alpha-synuclein. The biomarker as well could be considered looking like imaging. So we talked about before the DAT scan, but MRIs, we can get in a better quality MRIs to look for neurodegenerative disease. As well, the MRI not only to look there is a decrease of dopamine, is in somebody with Parkinsonism, we can do the DAT scan, we do an MRI. For example, somebody have multisystem atrophy type C for cerebellum, we see the cerebellum of the pons is smaller. Or somebody have progressive supranuclear palsy, and the MRI will show me the midbrain is smaller. We call the peak of the bird. So basically, that part is small. So we can correlate different biomarkers to distinguish the different Parkinsonism. Previously, the only biomarker we have was the necropsy when somebody died, looking for the different tissues. And again, Mr. Lewy described the Lewy bodies, but again, it's not only present the Lewy body dementia, is somebody had the alpha-synuclein. We talk about alpha-synuclein, getting closer, you see the Lewy bodies. And actually nowadays, in somebody have a complaint or concern about Parkinson's at early age, we do a screening for sense of smell, or he needs to have an appendectomy or just even a skin biopsy or any kind of tissue removed, we can look for the alpha-synuclein before any symptoms of Parkinson's. Okay, so we're talking about the different areas of the brain can be affected. We talked already about the dorsal motor nucleus of the vagus. The vagus nerve is very important for the motility of the gut. So that's already infected or get the alpha-synuclein, that can give constipation. It doesn't be affected as well. People can have syncope. So some people come to the office because they are passing out. And sometimes they have a little distension or the vagus nerve is affected, just having something like beans, cauliflower, or big meals, or go to have a very nice lunch and end having the hospital with a syncopal episode because distension, vagal nerve, and having this problem. So basically, I told you the progression when there is a decrease of the pigmentation, the substantia nigra. Nigra means black, right? So in the midbrain, we do the anatomical code of that. That we look for the typical Parkinson's. In the substantia nigra, the pars compacta, that's when you have the Parkinson's, but basically the pigmentation is decreased. And what is decreased? Because it's a problem with the iron. The iron is important not only Parkinson's. And some people suffering from restless leg syndrome. That could be something that precedes Parkinson, not always. Or somebody has just anemia, can have restless leg syndrome, and we use medication for Parkinson's, like pramipexole. We can do Requip, we can do Nupropatch. But you see, that's an issue with pigmentation in the substantia nigra. So that's why we always talk about the pigmentation in your skin. So you can have more risk to have melanomas. So it's very important for you always to check with your skin doctor at least once a year. Many people come for the first evaluation. I always ask if they have melanomas. And many people, the first evaluation, yes, say, yes, I have melanomas in the past. So be aware of that. So we see definitely in the past, we only make the diagnosis with the Lewy bodies when people were dying, but now we have the way to do biopsies and the way to do other biomarkers. And that's beautiful as well to do an MRIs. In the past, I remember I was a professor of neuroanatomy, so we do the slices, the cadaver, and show the students that this is the substantia nigra, but now we can do an MRIs. It shows live person. This is, I'm doing the slices. This is the person. So we talk about the genetic variants. Look at the variant I was talking before, the LRRK2, that it can produce Parkinson's disease, 1 or 2%, and is in familiar cases. And there's another presentation, the GBA1. We're talking about some monogenic Parkinson's disease or autosomal dominant Parkinson's disease. You know, in people that get Parkinson's in very early age, we call the young onset, is where we suspect it more genetic. So for example, somebody very young like Michael J. Fox, or somebody start the age less than 40. I have one case of 19 years old, 19. I sure probably they can have some people in early age in the pediatrician, but for me, the youngest I have currently is 19 years old. I was telling you about the Aska Western Jewish and one in North Africa ancestry. So there is a lot of ethnicity, and in some population, there could be more secondary etiology of Parkinson's. Looking for the young onset, we have the pink one, the PRK1, the AJ1. So there is some genetic variations, and in some people we can start looking at that. And actually, we make the diagnosis. Actually, that's included. If we find some genetic, usually we do more for research. If somebody is getting familiar Parkinson's or more prevalent, we can go from that. Usually, this genetic testing is not approved by insurance. Usually, it's paid out of the pocket. In some people, yes, but it's sometimes with this familiar. But the most part, we said 85% idiopathic. But I think the number is getting lower. The more we be less idiopathic, we're getting more information about that. So actually, there was the genetic program. I think they come and approach to us to look for people with Parkinson's, and they try to get to see if you have some of these genes to get Parkinson's disease or familiar or something. But I don't know what's neither they're coming and they're not coming. So in any case, is there. So we go on a little more about the GBA1 has been more prevalent now. So we do more research in that particular form of Parkinson's. So again, you have to look, there is very strong genetic risk. We have to talk about Parkinson's. So you see, instead to be 1 or 2%, they can increase the risk to 20 to 30%, that high. Okay. So again, looking where you're coming from, what's your family, is European, and if there's somebody Jewish ethnicity or coming from South Africa, or they come from North America, here from North America. We have some people, for example, our diseases, neurodegenerative disease. We have one of our fellow neurologists, Colombian, he described one family in Colombia with a lot of people with Alzheimer's. But there is a lot of studies in people in general population. The same happen with Parkinson's, getting more research about genetic. So that's why I said that there is a lot of experimental with Parkinson's, a lot of research. So you go one particular study, you have to forgive me. There is a lot. So usually our first tool or the first way to do it is our training. The clinical is very important, but we've been talking, there is a lot of biomarkers. There is a artificial intelligence placing piece together from the clinical, the biomarkers, population, ethnicity, exposure to chemicals. So all together in the future can help us more to make the diagnosis. So you see about the compounds in milk of the sponge. I may tell you about some these toxic take in the diary. Some people, oh, you can have Parkinson's because you consuming milk. So you know it's possible. So it's very important when you get all these products, be sure that is the more natural or more organic in that regard. Okay, so we looking about again and REM-sleep behavior. We have been seeing about the exposure to metals, even there is a relationship with vitamin D, diabetes. What about the inflammatory process in the brain? What about if you are exposed to a smoking or caffeine? You know, we're talking about actually, somebody asked me about nicotine in Parkinson's. There's a lot of research. And actually, you know, when we talk about 3 or 4 years ago about the prion theory about Parkinson's, and we talk about the good flora or the good bugs in your gut, we always said, wake up and smell the Colombian coffee. Remember, I had to promote my country, and coffee in a small quantity is good for your memory, and you don't have Parkinson's. Actually, coffee can prevent, Colombia can prevent you to have Parkinson's disease. The same with nicotine. Nicotine is supposed to improve or prevent you to have Parkinson's. The problem is the way you use nicotine. Again, you smoke. This well, we talk about the medical marijuana has some applications, but the way that you smoke the cigarette, that's not good for your lungs. But nicotine, as you know, is an active like coffee, and a good in a small amount could be good. And some medications in prescribed for Parkinson's, and nicotine is or caffeine, because you know people with Parkinson have a lot of problem with the sleeping or being too sleepy during the day, or they call narcolepsy, but it's basically having difficulty sleeping. So it's good for cognition, could be neuroprotective. This thing definitely shows some improvement or prevention, but you have Parkinson's, of course. Having more Colombian coffee will not prevent to have Parkinson's. Okay. So let's go for the natural history and clinical course. So that's any disease, we'll see how we call the prodromos, meaning how it start and now what the main symptoms, how progress, how fast can progress, and what the prognosis, and what happened, what's in the end, what happens. So basically, some people get bradykinesia. So they will go back to the basics. So bradykinesia in Latin, brady means slow, and kinesis means movement. Bradykinesia, so people start doing it, you see, once in the clinic, is slow. Then we call about tremors. The tremor usually in the two Parkinson's, so the typical Parkinson's start in only one side, right or left. You see, it can start in one thumb, then the whole hands, and then the whole hand, and then decrease and swing in that arm. Then we talk about the main ones are that, but again, always gait and balance. Many people come to us that I need a medication for my balance because my balance is good. Unfortunately, we don't have a medication to improve the gait or balance. I found amantadine sometimes can help the gait a little bit, can improve the energy, and can help with a little bit of dystonias. But the problem with amantadine, as you know, I told you about the story back in 1918 when people had the vancomycin or some Parkinsonia symptoms, because people getting the flu, people that are giving a medication for that flu was amantadine. Amantadine is a flu medication. And not people only getting better from the flu, they get better for Parkinson's. So we still giving medication made in 1918. So that's good because still now we have a better version of the amantadine extended release. It's called Gocovri. And that medication can give you on time, and is I find very useful with people with dystonia, meaning some people walk and have the toes crawling, and some no work for everybody. Again, we talk about medication, but for the most part, it's working very nicely. And I prefer to use something like that and not to use anticholinergics like Congentin or benzocaine because they help, but can produce a problem with cognition and can affect more the issue with constipation and the other things. So I prefer not to use that, but it could be the last resort. So with the time course of progressions, some people could be stable, some people can go faster, depends on the condition, depends on what age you start, depends what you did, depends on the genes, right? So remember, we call the ecologic triology. If we have a host, we have the environment, and have what produced the issue. So the interaction between the three makes the condition to go faster or not. You have the genetic. The host is the genetic. Then the environment, you are exposed to the pesticides or the pollens, or you were exposed to Agent Orange. And the other thing is the environment as well. Is depends what you do. You do exercise, you follow your good diet, you sleep well. So all of this is going to impact how you want to progress in Parkinson's. Okay, so going to another non-motor symptoms, again, are very important. So hyposmia. So basically people don't smell well, or not that don't smell bad, it's the decrease of sense of smell. And they, again, that can happen years. I said, no, I have no sense, but that's happening for me. It's normal for me. I said, no, it's not normal for you. It's something happened to the olfactory, and that's probably the beginning. That's the way the alpha-synuclein entered to your body. And that makes sense with the COVID, right? Lack of sense of smell. It sounds familiar, right? So autonomic dysfunction. So we talk about issue with blood pressure. When we lying down, sitting and standing, we suppose not feel dizzy. Many people come with this complaint and feel dizzy. So first of all, when you come in medicine, you say, what is dizzy? Dizzy can say is lightheadedness, or dizziness could be vertigo, or dizziness could be you have imbalance. So they know, I'm lightheaded, I feel like I'm going to pass out. So that, well, we say, okay, let's do the orthostatics. You have to take your blood pressure when you're lying down for 3 minutes, blood pressure and heart rate. Then after 3 minutes, you need to sit up, check your blood pressure and heart rate, and you feel dizzy, make a note of that. And finally, after that, stand up. And standing up, you have to have, after 3 minutes, blood pressure and heart rate. If the blood pressure, the systolic, the top number, drops in 20 points or more, usually we call orthostatic hypotension. And the problem is, usually the heart rate not compensates. So let me explain that back to you again. You're lying down, and you always explain like this. This is like talking about house. We have a lot of issue with the house, but again. So this is one-story house. This is the pump, and this is the master. Now they don't call the master, they call the primary, right? Primary, okay. Because other issues. Okay. This is the pump, meaning the heart. This is the master, meaning the head, and this is the legs. When you sit up, now it's a two-story house, but you move it like this fast, the master or the brain, the blood pressure has the tendency to go down. But you have a receptors here in your carotid arteries, and they sense the blood pressure is going down. They talk with your heart and tell you, no, the master is not happy, the pressure is down. So you have to pump, you do your job. So it does happen on time. If the heart starts pumping fast, then you don't feel the lightheadedness. And then you stand up, the same thing. But the autonomic dysfunction, that means that doesn't happen. And then the blood pressure drops, the heart rate does not compensate, and people start feeling lightheaded or dizzy. So that's we need this patient to use the medium compression stockings. By the way, summer is coming, so if somebody suffering from this condition, which it can get worse. So be careful with the summer or the heat, make the vasodilatation, can make the blood pressure drops, and I see many people with the autonomic dysfunction being bad. So that we're talking the autonomic dysfunction. But autonomic dysfunction is not only blood pressure. Blood pressure can be down, or sometimes could be up, all the way. It's like roller coaster. When somebody come yesterday and told me, no, but this is my blood pressure. And actually, they have it, actually, they are so good now, they have in the cell phone, and they show me the blood pressure, how, and they look like very nice roller coaster going to Orlando, the big ones. So you just imagine that. It's like you're to roller coaster in Orlando, you want to go, and then you will be dizzy. That happens with the brain. Blood pressure going like this all the time, you feel dizzy, not feeling well. So autonomic, when this orthostatic hypotension, we have treatment, but this autonomic dysfunction, meaning the blood pressure goes down, but go up, sometimes very difficult, right? Because you give some medication to increase the blood pressure, but the blood pressure rate sometimes spike high, it will be a problem because actually it can produce a stroke. But sometimes can manage, depends on the situation, one way to another. And talking about autonomic dysfunction, again, it's not only the cardiovascular. It could be a problem with sweating, could be a problem with the bowel more constipation. Urinary frequency. Many people have problems with retention or incontinence. So after many going to different doctors, they come back to me because, and they say, oh no, my urologist says okay. The gastroenterologist said my thing is okay. The heart doctor is telling my heart is okay. So, okay, I said, okay, bring it to me. Unfortunately, we talk about multisystem atrophy. Okay, so we just talking about all the thing, the sexual. We are very shy to talk about sexual dysfunction, but unfortunately that happens. That happens, erectile dysfunction. The way that you control your temperature. There's sometimes feeling irons too warm is cold, or the other way around. So unfortunately that can progress. Another thing that we forget talking upon intended is cognition. We forget about memory, right? So cognition, unfortunately, is another thing that's very prevalent in Parkinson's or Parkinsonism. So in some point, we talk, most of the time we talk about tremors or blood pressure, but we forget about cognition. At some point, we have to do baseline cognition. And it's very important for yourself to keep mentally, physically active because Parkinson's is placed you in more risk to have dementia. And the dementia in Parkinson's is called Parkinson-associated dementia. But I see a lot of people with Parkinson's now. We open the memory clinic as well. They can have Alzheimer's. Now we have the way now to diagnose Alzheimer's. Again, if I find it's not the normal aging process, so I found some red flag for Alzheimer's, we can do now beta amyloid PET scan. We have treatment for that, so we can have the Kisunla or the Leqembi, that infusions, but there's significant, like sundown. It's not the typical Parkinson or confusion, but you have sundown and have more of the phenotype of Alzheimer's than we pursue with the beta amyloid. So in some point, you have to have at least a MoCA. MoCA is no coffee and milk, is Montreal Cognitive Assessment. It's our score for a screening. The normal score is 30 of the 30. When you go from 26 to 29, we call mild cognitive impairment. Somebody between 20 to 25, again, is a screening. You will be in the case of mild dementia. Somebody between 15 to 19 would be moderate dementia, and less than 15 is severe dementia. So the new medication that we have, you have to have at least 17 to qualify for the new medication if you are in the case of Alzheimer's. Again, when the time comes, I'm sure we're going to get infusions for Parkinson's. It's in the research. So we'll, hopefully soon enough, we have to talk about that. But again, we have our memory clinic. If you have any cognitive problems, don't forget, found intended again to tell us about the cognition, and we can get a baseline neuropsychological evaluation. So talking about cognition, not everybody having cognition is Lewy body dementia. It's something that I see very often. It's like somebody have tremors, go to get, or have Parkinson's, go to get his license renewed, and the clerk just take it for granted, you cannot drive, you have Parkinson's. No, that's a misconception, and as well, it's a misconception thinking that everybody have a cognitive problems of Parkinson's is Lewy body dementia. So remember, Lewy body dementia, the cognition comes first, hallucinations a lot, and later in time, you have some flavor of Parkinson's. Different is you have the tremor first, and with the years, you start developing some cognitive, and finally, you can get dementia. That's Parkinson's associated dementia. You see the difference? Okay. That's very important. So it's very common, and just an example of the symptom, hallucinations. Hallucinations are very important in people with advanced Parkinson's or progressing or taking too much medication. It's expected. If somebody has for years Parkinson's, then they start having some cognition, I start having hallucination. Or aging process, just with more than 80, more prevalent to have hallucination. Or you're taking amantadine plus recycling plus pramipexole, you can have hallucination because the medication. But it's not the medication, just by itself, it's the cognition and hallucination, then probably you start having Parkinson's associated dementia, no Lewy body. You have no Parkinson's beginning, but you have the cognition and the hallucination from the beginning, and later in time you develop a little tremor, a little That's Lewy body dementia, fluctuation. And this is the difference. Just to give an example, you treat a hallucination with somebody with Parkinson's. I use a medication, it's called Seroquel. It works wonderfully. But you have somebody with Lewy body dementia misdiagnosed. It doesn't know it's Lewy body dementia. Let's give it Seroquel. Seroquel making it much worse. So that's the difference. And you know about Nuplazid. Nuplazid is a medication that we use somebody with Lewy body dementia. I just had one this week, and the wife is telling me, no, definitely Nuplazid is not that knocking out, but at least he's doing better. At least I have some time for the sleep. So Lewy body dementia is a very hard disease. It's very difficult for the caregiver. It's very difficult for the patient because they have hallucinations all the day. It's very difficult. They have fluctuations. They're very restless. And they're very picky and just looking something here, this and the black, they can go there. So it's a very bad disease to have. So it's very important to have the right diagnosis. Okay, you see the difference between one or the other. And you give an example of just one symptom. And again, having tremor not always is Parkinson's. I have many people, they're misdiagnosed with Parkinson's or the other way around. We've seen the clinic many times. Somebody come for a sensation tremor and say, oh, but look, that I hear suspicion. You have this tremor a little bit like that. It could be a little bit, Parkinson's. Okay. Okay, so we're talking about the amount that people can be diagnosed with Parkinson's, Lewy body dementia. So it's not our job to try to look what the subtypes of this. We talk different types of diseases of Parkinson's, Parkinsonism, and we are looking for the progression. So again, you can start with the motor symptoms, and then you can develop some autonomic dysfunction, or you can get some issue with cognition. So we getting there. Hopefully in the future, we start with some symptoms. We can get more biomarkers. Again, tell you, placing all the information together, we can actually tell you, you have this. This is going to be your prognosis. This is going to be your complications. And then we have the genetic testing is coming for everybody having Parkinson's. So we don't know when, but it's possible the same that we do for Alzheimer's that we do now for Parkinson's. So a little behind. Of course, Alzheimer's is getting a little more research because many people more affected with these conditions. So after Alzheimer's, Parkinson's is the second neurodegenerative disease. Okay, so looking about the different ways we treat Parkinson's, we always talk about the MLB inhibitors, which I love. I always said this is the cherry in the cocktail. So there was a lot of question about this neuroprotective. Again, there were different trials. There was one that's called the Abagio study, and sure, the design that the study was not good to show this neuroprotective, but for me, it is. Clinically, I see the improvement. Some people don't react well with them. It's not for everybody. It's like you want to get a new shoes. I have gout. If you the shoe, it doesn't fit you. But the shoes is good and they fit you, it's going to be amazing. They can improve. So we see many people come already with advanced Parkinson's over to the level of Distancia Nigra. We had a lot of trials for many things. So looking about the genetic, look at this is the big news in Parkinson's and the update in the new journal of medicine. So we had the pathogenic variants, the GBA1 and the LRRK2. That one is again more the acanasi, but the GBA1 is taking more attention in research because it seems going from the 85 prevalent to the 70 because this is getting more and more prevalent in Parkinson's, the reason to get Parkinson's disease. Okay, so everybody's different when you come to the clinic, I have to say, but this is not like a treatment that is going to fit everybody. So you have to be tailored, depends on your symptoms, depending on your variant. I do a different type of treatment, but again, it's not me only. It's a team. It's you. It's your care. It's your PCP. It's your family. It's the way you do every day. Again, I only 1% of treatment. You are 99% of the treatment yourself. So you don't are complying with the medications. You don't do the exercise, but we need assistance with the physical therapy, occupational therapy. You are in the right place here to do exercise, boxing, Tai Chi. So that's where they said again, and it's not because I'm telling you it's the New England Journal of Medicine. Everybody's in agreement that is very important. So we need he needs the family. You as a patient is your family, but you need to do your job, do your part. You have to come, do your exercise. Nobody can do it for yourself. So you do it, your exercise. We have to have the follow up with us, and I'm very happy you guys are very up to date with all the research. And many people bring me research and saying I'm very happy. We have always the Neuro Challenge. The once a year go to the expo. So I recommend you to go there and be up to date. And if there's something that you think is for you, but again, here in the area we're very blessed. We have in Tampa Dr. Hauser for research. In Gainesville we have Michael Alkin, and we have a very nice group for research in Parkinson's. So there's a lot of going on, and again, there's a lot of people coming to talk with us here about research. So remember, we need to tailor your medications. If you start getting some complications, our philosophy of treating Parkinson's is usually try to avoid starting dopamine straight. So we use MAO inhibitor first. That's the cherry cocktail. Then in that cocktail, I got the pina colada, they give you a dopamine agonist, you have tremors. So it's like pramipexole, or we give you something like Requip, you have tremors. And then in the time comes, you are in the age in Parkinson's to drink the alcohol in that cocktail, which is dopamine. You take too much dopamine, you get drunk, you have dyskinesia, you pass out, right? So that's dopamine. And when the medication is not lasting enough, then can use some medication to make it longer. So we can come inhibitors like Compton, now we have Ongentys. Or there is complication. At the point of complication, that cocktail to decrease dyskinesia, we do amantadine, and now the amantadine is on a standard list is Gocovri. So now we have, remember that the sooner I start level dopa of the younger age or the significant amount, most likely you develop more of these motor complications with dopamine. So I mentioned already when in that cocktail, give the dopamine agonist instead of start you restrain dopamine. We're looking at the half-life of dopamine, and we have been talking now in the last talks about the Crexon, and we're talking then, somebody have something to say about the Crexon. It's the best delivery system we have pill-wise. So I'm very happy that's our iPhone 16. That's my example, right? So people have still some iPhone 1, still you can talk, but don't use too much. That the Crexon is the same carbidopa that described. I have been treated for many years, but now we have the best delivery system so far. Now we have as well a pump. They got places attached to your skin. They have a pump, you go there. Previously, we have another pump that was to go you got. And people that I actually tried to get a pump for a couple of people in the past with the for the Duopa, which is a gel that go in the pump, go to a tube to you got. But before that, came back Rytary, and Rytary works wonderfully. And then we have this. So we don't want to be too invasive, but now we have as well a pump for apomorphine. Apomorphine is not narcotic. It's in a beta, it's a dopamine agonist, and we use it before for people having more off episodes, but it's a pump now, just in case. Just you need to be aware. So again, depends on the situation. We have more resources. And I think the guy from Inbrija is going to come today. He gets lunch. So we have as well a powder. It's called Inbrija. The Inbrija is a powder that goes to your mouth. You have an episode off. You can use the medication. You can get in your purse. You get it off. You use it, and very good. But again, it has to be for somebody really the blood pressure doesn't drop too much, because somebody have problem with blood pressure and get this, he gone straight to the ER. So we have been talking about the COM inhibitors, MAO inhibitors, so the cocktail, the different types of medications that we just talked about, the dyskinesias. On demand, I told you about sublingual. Before we had the Parcopa that for some reason they took away the Parcopa. It was a sublingual form. And since then it's out of the market, I use more the Inbrija, which is the powder. And sometimes people doing well, I see the blood pressure, no them, the blood pressure, no problem, and you get enough. I give you a sample in the office, bam, in 2 seconds, they do much better. So because this, remember, the medication used under your tongue, like somebody having a heart attack, they work like that fast. So this is the Inbrija. Inbrija is only levodopa, because doing it straight to the to the bloodstream, you don't need the carbidopa because they're not going to your gut. So you don't go to your gut, you don't have nausea. Carbidopa, levodopa, Sinemet without vomiting. But it doesn't go to your stomach, doesn't give you nausea. Some people say yes, still, but it goes straight to the blood, so it doesn't go to the gut. So that's on demand. Remember, like Netflix on demand? Okay. Apomorphine. Again, in the past, there was a medication with given only like an injection, and there was a issue with nausea. We're using a medication for nausea that was taken out of the market, so we don't use it that much. There was a form of the apomorphine that was sublingual, but again, because the Tigan, that was the medication for nausea that we're using with that medication together, was taken out of the market. I don't know why. Probably the DA was thinking that was not safe. So unfortunately, that medication was great, was taken out of the market because we don't have the nausea medication, but not have the pump. So we'll see how they work with the pump, because the pump hopefully is not going to have the issue with the nausea, but still. So we'll see. So there's all the excitement and the New England Journalist talents where we know. And this is the next one is going to be a very busy, it doesn't show there, but it's a very busy, let me see, it's in the thing that the get stock is not showing up. Right there, okay, I got in the this. So that one is very busy, just showing all the medications that we have available for Parkinson's. So we go from the levodopa, the dopamine agonist. So levodopa, we talk about the regular Sinemet, we talk about the Rytary, the extended release, which really sometimes works, but we don't mind about the absorption is very erratic. We have been talking about Rytary, we have been talking about the Crexont. Now we have the pump, we have the Duopa. Talking about dopamine agonists, we have the Pramipexole, Mirapex, alias Mirapex. We have ropinirole, Requip. We have apomorphine. I just tell you, this is not morphine. It's not narcotic. It's a dopamine agonist. And now it's not injectable as well. You have a pump for that. We have MLB inhibitors. The one I love and one of the medications I love the most, since I was arrested, I call it vitamin A, is the Aslec. I used to the cherry in the cocktail. It's Resagiline. But in the same group is Selegin. The Selegin usually is 5 milligrams twice a day. And in Europe, sonazamide, and we have samples. I've never used that. I love the Resagiline. Just getting all. I just stick with when medication works. I know the side effects. The ones I don't know much. But if somebody want to use it, it's okay. Or somebody comment that medication, I continue with that one. The COM inhibitors or catecholamine or methyltransferase inhibitors. You see, very easy. COMT. The entacapone and opicapone. So opicapone is the Ongentys. It's a very expensive medication. It's only once a day, and the same company, they have the Crexont, both that company, but honestly, I don't get the medication very often because it's good that when it enhances your dopamine, but the Crexont is enough. I know you use some more expensive. I tried a couple of people, didn't work that much. It's very expensive, but it's not a resource. No, you never say never, right? So it's a resource, a good resource, but I don't use it that much. We have another medication that was okay with a lot of noise, and we tried to use it many people, and still I have a couple of people using it. It's Nurians, and they said a different way to use the dopamine is adenosine. Unfortunately, I got a very disappointed. And have a conversation with my patient and see if you really think this working, you know, I had to take it away. I know he's here and he knows. Okay. We use a lot of, in the past, actually, psychiatry use a lot of people having, they using medication for psychiatry, producing some Parkinson's. They usually, in that scenario, we can use the acetylcholine inhibitors or acetylcholinesterase medications like 3-hexyphenidyl or benzotrip is anticholinetics. Actually, I say wrong, it's anticholinetics. I don't like those medications because that produce more problems in Parkinson's. Cognition, more blurred vision. I don't know about constipation, could be the problem, but for the most part, I don't like them. But in the scenario, people having drug-induced Parkinson's is something can use, or nothing is working. And one of my colleagues using a lot of that in people having tremors, and sometimes the tremor doesn't work with nothing else. But I have 2 or 3 people, and these medications are too much. I don't use those much. So the MDA receptor antagonist, we just talk amantadine, right? The flu medication. So I'm going to cover it. Okay. So we have been talking for the no motor symptoms. We don't have too many medications. So it depends what looking, again, there's a lot of research about what how to work if you have depression. Of course, there are medications, but for fatigue, exercise, we're talking sometimes like Ritalin or some stimulants, hallucinations or cognitive. We like to use acetylcholinesterase inhibitors like rivastigmine, excellent patch, we use a lot. For psychiatric symptoms, so at some point, people having psychiatric symptoms, we have to do dopamine antagonists. So I have to look what's worse. So if there's psychiatry, we have to use something like Seroquel. You have an issue with the sleep or depression, is good. But then I know I will make the Parkinson's worse. Autonomic symptoms, including orthostatic hypotension. So initially, we have been talking about this and have been in different talks about increasing the fluid intake. It's very important, water with electrolytes. We're talking about the medium compression stockings. We have been talking about the band. And I remember, this is going to be, unfortunately, in summertime will be something will come in. Like you have, you're the hurricane season. We have the summer season for people with orthostatic hypotension, so be aware of that. So we have medications that can increase the norepinephrine, like the droxidopa. This Northera is actually for this particular condition. But before that, we had an steroid, the fluorocortisone or Florinert is an steroid. So they can produce almost the side effects similar that you take an steroid. But it's a good, and some people do very well with that. But you need to be aware that you have all the same symptoms. Yeah, you have like prednisone or something like that, probably in less degree, but you have problems. You can have midodrine, which is alpha 2, and with that actually is what probably the first medication I would choose. If it doesn't work before going to the droxidopa, I can go to the fluorocortisone. Always mention that it has side effects, and then we can use the droxidopa. So to my resident, I always said, oh, okay, we have an interesting case. I will send you this article. So the droxidopa, I want to give you an example. I had one patient that was working intercostal, and she had some problem with orthostatic hypotension. Actually, I remember she was referred from my dear colleague, Dr. Francine Martin, gastroenterologist, that she's now in Orlando. And I examined her. I said, you need to have to do that scan. And they look at me like I have two heads. And then we found that that's positive. Initially, she has only orthostatic hypotension, but nowadays she get all the symptoms of Parkinson's. So we start with orthostatic hypotension, and now has some flavor of Parkinson's. Something that we always disregard sometimes, which is very common, is no motor symptom, is pain. So Parkinson's can definitely produce pain. You think about there is an increase of the tone of the muscles. There's another type of pain. They're more predisposition to have arthropathies or neuropathies or multifactorial. So Parkinson's actually can, when you have more wearing off, because more spasticity, that aggravate you pain. Whatever the pain is, especially joints, that can be affected by Parkinson's. Okay, so the main treatment or the cure for Parkinson's, we don't have. So we are researching for that. I'm sure we get the cure and not be workless or jobless. I think we have a lot of problems in movement disorders, but unfortunately, we know there is a lot of research. Unfortunately, with the same with Alzheimer's, we are in, because this is a neurodegenerative disease, we have been a lot of work from inflammation for alpha-synuclein, monoclonal antibodies, look for antioxidants. Now they are proposing medication that we're using for diabetes, like the ones to Ozempic, or there's a new one for the sleep apnea. All of those have been in research. Even the Ozempic was in research to look for preventing Alzheimer's. So there was a study in a group about that. And I see actually people having treated with the Ozempic, the patient, look at that. Is that telling me that probably that could be the cure for Parkinson's? So we'll see what happens. So what is true today could be not true tomorrow, or vice versa. So sleep apnea, REM sleep behavior, we use a lot of clonazepam. Again, it's benzodiazepine, but it's quality of life. And some people can make it more confused, or if they stop it, they have seizure, but for REM sleep behavior is very prevalent in Parkinson's. It's something hard to talk, or in Lewy body dementia. So again, this is a little bit of the other medication that we use for no motor symptoms. This is not the same table. So looking for For memory, the rivastigmine or donepezil, from a medication for memory, memantine. For antipsychotics, for people having Lewy body dementia, we use the this is the generic for Nuplazid, is the Cipramine. Oh, we're using as well clozapine. Clozapine or Clozaril is a medication that is managed by psychiatrists. It's a very good medication, but have a very nasty side effects. Can produce agranulocytosis. These people need to have blood tests like at least once a month. Well, I think you're getting overboard here. So you try to let me know. I can stop anytime. But this is the review, almost there. So you let me know. I see somebody falling asleep. I stop right there. But so far, you guys are good. You're almost finished. This is a good review from probably nothing new, nothing we're talking different, but I think it's very explicit going through the all symptoms, motor, no symptoms of Parkinson's, and it's available in the New England Journal of Medicine. So it's a very good place of reference. As a medical student, a physician, I love the New England Journal of Medicine. I do my CMEs, usually very interesting cases. It's a good New England, a new place to find out the news in medicine. So for the orthostatic hypotension, we talk about the droxidopa. We talk about even the medications we use for myasthenia gravis, the pyristomine, we use it as well for orthostatic hypotension. And it makes sense in Parkinson's because guess what? This medication produces diarrhea. So you have constipation, you have orthostatic hypotension. So that could be good for you and give more energy and get for orthostatic hypotension. That's something we use sometimes in the clinical aspect. And sometimes we use stimulants as well for orthostatic hypotension just to increase the blood pressure. Sometimes we need to use medication like Botox. So people having sialorrhea or having dystonias, so we can use botulinum toxin. So botulinum toxin type A is branded is Botox. Botulinum toxin type B is Myobloc, and the Myobloc we're using for sialorrhea, which is something very common in Parkinson's. So you get the issue with sialorrhea drooling all the time, we can treat that. Some people use atropine or some drops. I usually don't very keen on that because that can produce arrhythmias of the heart, but it's not an option, but I prefer not to do drops or use any kind of medication. If the sialorrhea or drooling is too bad, we can do injection in your parotid gland, in submandibular gland, and usually it's approved for Medicare, and they do it every 3 months. But some people do it every 6 months. It's not bad. You say whenever you feel you need it, you let me know. Okay, so we have been using the normal medications for urinary problems. So the urinary problems, we usually send it to the urologist, but we're using like basic care. Sometimes even bottles have been injected there. So we got different medication for erectile dysfunction. Again, don't be shy to tell us about this, but again, this medication like Viagra or this Nefenil can produce issues with blood pressure. So have to be very careful with that as well. So risk for having a stroke. Okay, well, we can stop right here. We talking for a long time for DVS. So to be continued. I don't want to make you tired right now. Thank you for attention, and I'll be open for questions. And again, April 11 was the International Day for Parkinson's disease. So we celebrate the awareness of Parkinson's. So time for questions. Yes, thank you. I thank you for being the first row. Thank you. Thank you. I appreciate it all the time. Thank you. You have always a good mark, always in the first row. Yeah, and I'm told, because okay, so the question for the people in the Zoom is, in the one slides, we showed that many people diagnosed with Lewy body was indeed actually done at the time they died with apoptosis. That's what the meaning of that slide. So nowadays we have the biomarkers. So now we can definitely look at you have Lewy bodies in your body, and Now that the diagnosis is clinical, and with the new resources we have, actually, I sent it to Dr. Rodney. There's an article for Lewy body dementia, so it's not only the autopsy. So you have to go a very good ways to make the diagnosis. So there's a lot of things you have to hit to make the diagnosis. So basically, first we have the clinical, definitely the cognition is first, and then the issue with and hallucination first, and then you have to have one other criteria. You have the REM sleep behavior. Then you have to have the issue with the fluctuation during the day. You are alert, and then like sleeping, that's another thing. And there is another DAT scan, but there is another nuclear medicine test that we can do to diagnose that, the difference between somebody had the Lewy body versus no Lewy body. So we are in the point again, I show you the beauty is that before making studying anatomy, I was an neuroanatomy professor before we had to do the cadaver, but now we can do live with MRIs, and we have the ways to diagnose in vivo when people are alive. So Lewy body dementia, now we can make a diagnosis clinically. We don't know to do the autopsy, but again, you have the phenotype and looking for the other criteria. You can have a sleep study, all the nuclear medicine, and finally we there. But again, most likely you presented with Parkinson's, the cognition confers probably not be Lewy body dementia, probably not. Most likely 98% tell you not. Any other questions? Okay, very good. So we finished the questions, and now everybody wants to talk about our updates with Crexont. You want to talk? Please.
Very well.
Thank you.
Even with the different times that I get up in the morning, usually wake up about 6. So I've been taking it 7, 7, 8, 8. Depends on the day.
So that's beautiful. What I'm saying is about the Crexont is getting better, and one of the things is the convenience of the schedule. And some people, when go from the regular carbiopulmonary, instead of taking 3 times daily, taking only twice a day, it's very convenient. So you take in the morning when you wake up, and before you go to sleep, or 7 and 7, 8 at 8, or 9 and 9. And then you can do whatever you do in your day. You have to worry. You have to eat all the protein. You want the barbecue. You want whatever you want, and that's fine.
But I take my settling at 9:30, same. Gives it a boost.
Okay.
So,
So thank you so much. So this is again, it's different when patient talk, when I say it, and again, I don't have any economic interest in this medication. I just very passionate, and I'm so happy here and hear over and over people doing better. And again, sometimes we try, it doesn't work. I say, please try a little more. I always say 1 week, 2 weeks, 3 weeks. I had somebody, and what I found, honestly, one of the more difficult is do the transition between Rytary. They're supposed to be the same molecule, right? But it's improved from iPhone 10 to the 16, supposed to be better, but not. It's better to go from the iPhone 1 to the 16 straight. Because with the Rytary, we don't know exactly what the dose, what the absorption. I many people do very well in Rytary, so it's better to, for now, I'm thinking better, keep people Rytary. And initially, my problem with Rytary as well, they said is milligram to milligram. No. Crexont is more potent, it's better, and sometimes the issue is giving more on time. You got milligram to milligram, and sometimes we don't get the right dose with the Rytary people. So sometimes said, okay, try, but if not, and give you the hands up. So the question is for a caregiver, one of my love patients here, she's asking as a caregiver, you see, I always say the last word at home when my Vivian is down there. So the caregiver is the boss, right? So basically, you have to listen to that, right? We're in the same club. We're in the same club. But it's beautiful to have that. So basically, ideally, we are a little flexible in Parkinson's, but with this medication, in the ideal world, is better 12 hours. But again, it doesn't need to be that as much you can do it. But if you miss 1 hour, it doesn't matter. It's better to be stable because the medication is designed like that. You are stable, you have more steady ride. You a little bit, you get a little bump in the road. Say, no, no, I forget to take it, or it's because I take a protein with it. So it's better to stick with that. But the beauty of this makes you a little more flexibility. So I want to be less anxious about that. Try your best to do it, but you miss for 1 hour. Don't be too worried about it. Yes, doctor. Mm-hmm. 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 And guess what? Probably medication to give you an extra time, right? So that's the beauty for this. So what doctor is telling here, by the way, I'm very blessed to have as well one patient as well, one of my patients Parkinson's with. I love as well. I love my patient, but I know last time we did an honor for him, he was playing the piano. So we appreciate he does for us. So basically, what he's telling as a patient, not only as a physician, sometimes going to the previous question, he's supposed to take 3 times daily, but he missed one. Sometimes the medication give an extra time. So that's great, right? It's different than normal medication that will give you an extra on time. So that's a little more flexible. I forget, but guess what? Your body not telling you miss it. So probably you need three, or probably you need in between. And the thing is, you're doing great. So at least, if not great, that has been changed your quality of life, right? Back in the day, you miss one dose, you get it off. It's freezing. No, the medication, it give you a little more lead time, give you a little more time for you to adjust. And again, it's a little more freedom with the meals. So you take it at 8, and then say, oh, I have a picnic at 12, so I don't have to worry. I have to either delay to 11 or it's 1, it doesn't matter. You have your life, you have your time. It's a potential spam. So I love the medication because of that. And this medication and the Rytary has been hesitate me to place people in more aggressive therapy or going to more invasive therapy. So it has been changed. And insurance is getting better and better with this medication. It still could be expensive. I know for people getting, again, I don't have any economical thing in this, but you see about everything is getting expensive and expensive and expensive. You go to get a small steak, and I have to go dinner. So I always go to my big boss. I don't have dinners with when I speak. I say the dinner, and I buy my wife. So you get a steak, one steak like this costs almost $100. Yeah, you need to one of these steak thing. It's $100. So you have to spend $100 for 30 days. It's okay. It's okay. It's your good being is freedom. So invest in yourself, right? You deserve it. So why you sometimes you buy things like a cloth, or you got something choose very nice. Why you get invested in your head is good. And again, I agree. I don't know why those makers are so expensive, but that's the way the pharmacy all the companies making the makers make the money, because when they are branded, they do the big money, and then after that, when generic, then they don't do the money. So unfortunately, that's the way. But you see this medication in different countries. It's not so many medications in this country are very expensive. You go to a different country, it's less expensive, right? Like before we said Canada Pharmacy, something, but the branded, that doesn't work that way. Okay, any other questions, or somebody else want to talk? You say, "Ah, okay, that's exactly." So she was saying that her husband was 6 months in medication, and he's great. And I know he's great. He's great. Yes. Okay. Any other question? Yes. That's why you're coming to us. So the question for her is, she said she's probably misinformed, but she doesn't know anything about Crexon. So that's why we're doing this. And actually, we have been talking in the past, in the previous talks since last year. We said something is coming, something is coming. In the previous talks, and you can get access, we talk about new findings in Crexon. And one of my talks had been like 2, 3 months ago. And actually, I presented the medication. And actually, one of the person that did the research was, we're very proud, is with Dr. Hauser. Dr. Hauser in University of South Florida, he was one. And he's a very good talker, and he is part of the Neuro Challenge. So he was one, and actually we have a webcast with him and a couple of another doctor in Boca Raton and one doctor in New York. So they tell us about this. So we go to the different ways of this. So let me explain this to you. So basically, I guess this, just make it short, what's correction. So you can get an iPhone, and still you take an iPhone and talk with the iPhone 1. That's the Cinemed. Cinemed is carbidopa, no vomiting. If the technology or the cell phone, they get updates of the software, unfortunately, you can still use an iPhone. It's an iPhone. You can talk, it's talk, right? It's carbidopa. An iPhone 10, more technology, is Rytary. Rytary is carbidopa, but is really an extended release. Microspheres to go to deliver slowly to give you more on time and avoid this motor fluctuation. So maybe to go on roller coaster like this, taking every 2 hours, you take it every 4 or 6 hours. That's Rytary. But again, it's carbidopa. Now we have the iPhone 16 is the last one, right? Unless I don't know if they say. The iPhone 18, carbidopa, Crexont, Crexont. It's carbidopa. The main thing about this, again, is the delivery system. So it's the same carbidopa, but the technology, like in the iPhone, have 3 cameras, you have the video, you have. This is going to have a polymer that attached to your stomach, and they have immediate release to pick up. That's why the beauty of this, that immediate release first, and that's when the layers have an extended release. And they deliver very slowly, so that give you at least 1.5 hours more on time, because the way delivered slowly. So you have the medication is not the immediate release, that have the peak and get out, and that's it. So this medication give you more on time, at least 1.5 hours more than the regular carbidopa. And the beauty of this, you're in regular carbidopa, not less than 500 milligrams, you take it only twice a day, 280 milligrams. I look in the conversion, you're taking 100, it is more convenient. You're taking an 8 in the morning and 8 at night, or depends on your schedule. You wake up at 9. I hope I can I wish one time I can wake up 9 in the morning, and take a 9 in the morning and 9 at night. So you choose. It's beautiful. But again, my ratio in the beginning was 9-1. Now I have like 7-3. And some people, again, it's not for everybody. Again, it's like somebody going to get a bite juice and they have a bunion or a gout attack. You try and you just, no, I don't like that. So it's, and many people works very nice. And some people have the hesitations, and some people don't get better. And sometimes you say, no, let's try different dose. That's sometimes difficult, especially if people already Rytary, it's very difficult to get there to the right dose. You got more or less I answer your question? Sort of, okay. So what part you missed? It is new. Again, it's like iPhone. The iPhone 18 is a new iPhone. It's more technology, but it's still an iPhone. So it's the medication, the gold standard of treatment Parkinson's is levodopa. Carbidopa is to avoid nausea. Just getting the different delivery system. A car is a car. You can get a car 1930 and you can move the car. But now you can get a car, it's automatic, it's a car that get very right. It's still a car, you can move. You understand? You can get a car from the classic, it's very nice, but you cannot expect to go 100 miles per hour, right? So that's the same thing. That make you a little better? A little better? Okay. She said it's a little better. Cheers. So the question is that she has a new primary care physician, and he has been recommended nicotine patches. So the answer is, I don't dismiss that. I will take it like could be an option. I don't use it every day. Has been a lot of research in the nicotine for more energy, for memory. So I personally don't prescribe it yet. I like to have more evidence, but I think it could be a good, but you have to look as well the side effects. So remember, nicotine, I told you today that could be prevent Parkinson's, but you have Parkinson's, will not prevent it anymore. But it's like caffeine is a good medication for activation, for You looking for fatigue, probably, as well to keep you awake. That's why people use the nicotine. But as well is medication can produce issue with the heart use too much. So I have to look for the side effects. The same with caffeine. Caffeine is good, but depends on the amount that can be an issue with the heart. So I have to look for the side effects. That answer the question more or less? Okay, thank you. So let me investigate a little more about intelligence. I don't use it right now. It has been in research for a long time. The nicotine, I tell you, nicotine like medical marijuana or marijuana has been there. It's another resource, but I use it very often. Not probably we use it more in the future. We have more evidence. I have more experience. I don't use it right now. Okay. Thank you, everybody.